There he is, Mr. Indiana, Mr. New York Times, Mr. World Traveler, Aaron Carroll.
Doctor to you, excuse me.
Oh, forgive me, sir. You're still a doctor. You're still?
Of course I don't care. That was just Mr. What do you do?
No, I think it's true. I think that you should tell people that behind the scenes, you actually corrected me in a text, which I thought was really surprising.
Yeah, that's right. Exactly.
Doctor, please, in a text.
Yes.
So, wow, great piece. I want to talk with you about it. I've just told folks a little bit about it, but tell me a little bit about these trips. I knew you're taking them, and I knew they came from different grants, right? And they were a little bit of a mixed match. But the bottom line was you went to these different countries and you studied their healthcare systems. I thought you were just like drinking whiskey by the pool.
No. In fact, they're much less whiskey than usual because that's not really the focus of many of these countries. Alcohol. That just didn't come out right. I guess what I was trying to say is that they're not as into whiskey, all these countries, as we might be.
Well, what did you go to? I feel like one of them, at least maybe Singapore, doesn't allow alcohol, or not?
No, Singapore has alcohol. In fact, there were lots of bars and stuff in Singapore.
I just made that up.
Yeah, it's not a lot of chewing gum, but definitely they still have alcohol. So I mean, every year, I'm lucky enough that is part of the Kelly School of Business, which is part of IU. Has a program called the Business and Medicine Program. It's an MBA program for MDs. I give a lecture or two in there, and I talk about international healthcare systems. But as part of their learning, they offer a course where in February you go to visit two countries' healthcare systems. So in the past, we've been to Singapore and Malaysia. Last year, we went to Switzerland. Not last year, but before the pandemic, we went to Switzerland and the Netherlands, and then this year we went to the UK and to France. And so I was thinking, trying to think I really want to pick up a larger thing to talk about with respect to, what I'm learning from these trips. But then I got offered an opportunity to travel with Academy Health and the Commonwealth Fund to go back to Singapore and to also go to Australia and New Zealand. So been a lot of travel in this year, but they're very different healthcare systems, and I really wanted to try to think about what take-home message could you learn from this, and how could we have a more productive conversation about healthcare? And I really became convinced that we're arguing about the wrong things, and so this was a great opportunity to sort of take all of that together. These amazing opportunities that I had to learn about other countries' healthcare systems, and to talk about what we as a country could learn from them.
You say we need to get more creative with our system after studying those 5. And the bottom line is you taught us years ago when we talked about this issue pretty much every week and every day in the media. It was a discussion during the argument over the Affordable Care Act, healthcare reform, that there are 3 pillars to the stool of healthcare. There is access. Can you even get a doctor's appointment? Can you even get care? There's affordability. If you get in that doctor's office, can you afford to pay whatever the bill is? And finally, if you got a doctor's appointment and you could pay for it, was it any good? So right. Quality, access, affordability, or cost, and quality. Those are the 3 pillars. How am I doing, Professor? Doctor?
You're doing great. But, the problem is that we've been arguing about the same thing for decades, and that's just basically it's really access, although you could argue a little bit because it's insurance. Like, how do we get people covered? And we've solved very little in those decades. We still don't have universal coverage, and that's what we argue about. And for every other country, that's the easiest thing. They've gotten to universal coverage. What I've really learned is that they get there in different ways, and it doesn't matter. Like, no one else, when you travel to their country, do they really spend a huge amount of time debating or talking about, should we change up how we give insurance? They're like, they figured out a reasonably simple means to do so, and they just do it. And it doesn't matter whether it's a fully socialized system or a single payer system or tightly regulated private insurance or massive dependence on personal savings and health savings accounts. Like, that's the least important part of it. And that's what we spend all our time arguing about.
Yes.
And the fact that they've figured out some relatively easy way to get to universal coverage allows them to focus on the stuff that actually matters, which is, quality, the providing of health services. We don't ever talk about that and what that might do to improve our health system.
Well, a lot of people, one of the arguments is, oh, we have access, we have emergency care. We're not even going to go there. Let's just talk about insurance because that's not health care. That's my legs falling off. My stomach is exploding. That's not health care. That's not what we're talking about.
But that's also, that's also one of the things I think it's important to focus on is like, that's what we think of as healthcare. That's not what other countries think of as healthcare. You know what? I've been to Singapore now twice to learn about their healthcare system. And twice I've been subjected to like a half day focused on housing. And you might go, well, why housing? And it's like, if you come to Singapore and you're like, I want to learn about why your healthcare system works well, they talk about housing because it's a social determinant of health. And if you give people the stuff that matters, like housing and food security and education, it turns out they also are much healthier. And Singapore has a ridiculous housing system, which is amazing. I think like 80% of people in Singapore live in public housing.
Wow.
And 90% of all people in Singapore own their home, including public housing. Like it's massive. And it's like that levels a playing field where, if you invest in those kinds of things, Singapore spends like 5% of their GDP on what we would consider the healthcare system because their people are healthier. And if you go to Australia, we were in Australia. We talked to people in Australia. And you're like, why do you have like such good outcomes? And they're like, oh, it's not the healthcare system. It's like our healthcare system is good, but it's it's just as good as everyone else's, excepting the United States. It's that we also invest in things like food security and things that are like we would consider to be more safety net or public health. That's what they think leads to better outcomes. And we don't even consider that healthcare. Like we consider healthcare what you get when you're already really sick. And that stuff turns out it's not nearly as cost effective.
I feel like next you're going to tell me a country you visited where they look at one measure to spend or increase better healthcare outcomes by investing in education or something like that. Because you said housing, you said food security, and
education's there too. It's like it's just there are things that matter so much for health. We don't consider those things healthcare. We consider healthcare only really the stuff you get when you're sick, or like at very last stage, maybe trying to catch or prevent stuff that makes you really sick. But we don't invest nearly enough in all of the stuff that makes you well or keeps you well.
And we still don't have a very good conversation about it, most of us. But let's stick with insurance and access for one more minute, because I think to me, I recently heard America's original insurance sin is connecting insurance to your employer, because
hold on 1 sec. Loki's scratching at this door and he's not going to let me rest. Hold on.
Come on in, Loki. Join us.
He's trying to get out.
Lee, is it me?
He'll be back.
Loki.
I'm
sorry. No. Loki hates talking about health insurance.
He thinks there's other people out there he might want to see, and he's going to realize there's not.
Loki's about to be disappointed, much like the American health insurance consumer. Okay. I don't care. Loki can't get me off track on this issue. Employer, you have to have a job, and your job provides you with insurance. That's pretty unique, and it's really terrible and super depressing.
Yeah, we are, in fact, we may be the only system I can think of that has like such a huge employer-based healthcare system where it's tied completely to your job. Even other countries that rely heavily on private insurance, like take Switzerland, it's totally uncoupled from your job. You could have the same health insurance from birth to death. It has nothing to do with where you're employed. That's like, no one defends that as a good idea. It's just a trick of World War II and IRS policy for why we have that system. It's silly.
But the thing to me that's really the hardest thing to overcome is that we have this system, and you can't just redo it overnight. Specifically, employers argue, well, this is a benefit. We give our employees, we give them better health insurance from the super insurance agency, and they do health insurance better. And there's millions and millions of dollars in private health insurance. Everybody knows the names of these companies. And there's millions of Americans working in those companies. You can't just get rid of them, sir.
So don't. This is like, again, I think the point of the piece. I'm like, just stop arguing with that. This is stupid. Like the idea that because we can't change insurance, we can't change the system, misses all the things that we could do that have nothing to do with insurance. Like I actually think the biggest difference between all of these other countries and us is that they have public delivery systems. They have government-run hospitals that provide good care at rock bottom prices. And if you don't need to compete and you don't need to build it up with all of these kinds of amenities, you can get reasonably good health care to people for much less money. And it's those public delivery systems which matter, not the publicly delivered insurance. Every one of them, most people get care in a public facility. Now, they also all have private systems you can absolutely pay for if you want, and they're fancy, and they have better food, and you get definitely better service, and you get what you want faster. And some people choose to pay the extra money or pay for extra insurance to go use that private system, and the government's fine with that. It's like, we're going to provide a public system which relatively cost effective and reasonably cheap, and then there's this private system if you want to pay for it. That is something actually Canada does not do, and I don't know why we only compare ourselves to Canada. All these other countries, mostly public system with a private, release valve, that seems to work really well. But in the United States, it's the opposite. Almost everybody gets their care in a private hospital. Some of it is nonprofit, some of it is profit, but it's all competing for revenue. It's all competing, with amenities and trying to be super fancy, and it winds up raising the prices, and we all pay more.
Can you?
And I think that's the big difference. We could do that without revamping the system. We could try to invest more in public hospitals. We could lean in that direction. We could explicitly accept the tiering that all of these other countries do, where it's like most people get good, basic, not fancy care that actually works. And if you want to pay more, great. But we sort of resist that tiering in a weird way, which means that sort of everyone sort of gets the same, and we're paying for the wrong stuff.
So your answer to the private insurance or the access issue is better delivery. So you sound like a real socialist. You want the state hospital, the public hospital, the socialist hospital. That's what you're suggesting we do here.
I think that we could achieve more for less if we allowed for more public hospitals, and then still maintain. I have no problem. We have a private release. People want to get more and they want to pay for it out of their own pocket. Feel free. Like, I don't care. And these other countries don't care. Like, they're like, go ahead, spend more if you want to get it what you want faster, or to have fancy food, or boutique service, or whatever else is going on. Feel free. But we're also going to provide over here really good basic care without any of those amenities or any of the fanciness. And I actually think that would lead to better outcomes. And I think it's what most other countries do that we're lacking. But again, we're so focused on how the insurance is going to work. We don't ever talk about the delivery care. And we also, we could invest in better policies to take care of those social determinants of health. Like, you could do that at a state level. You could turn around. You could have better housing. You could have better, food security. You could have better education. You could have, we can fix disparities and racial inequities. All of these things matter too. That does not require a revamping of the entire system. We could just choose to recognize that these things matter too. Somehow, though, we've gotten into a blind alley where the only debate we have about healthcare reform is how do we get people insurance and how do we pay for it? That's the easiest part. That's the stuff that every other country's done already. Like, they're like, oh, that's just pushing money around.
Right.
We got that. And I don't even care anymore how we do it. I don't care if it's single payer. I don't care if it's, we have a total private insurance system like Switzerland. I don't care if we go, more health savings accounts and personal spend I don't care. I just don't. I just wish we could get past that and then start focusing on the stuff that actually matters.
So I don't know how we got in that blind alley, much less how we're going to get out. But I think most important point that you make, and you've made this for years, is we spend about 18% of GDP on healthcare. That's almost $12,000 per American, you're right.
Per person.
It's about twice what other countries currently spend.
And that's the irony, is that when you go to these other countries and you look, they all have, none of them are perfect. They all have issues. Sometimes it's wait times. They recognize they have an aging population like we do. There's new technology and it costs a lot of money and they're worried about it. So they fret about many of the same things we do, even though they're doing so much better. But when you say to them, like, well, how could you overcome this problem? They're like, oh, we could spend more money. That's what would solve it. Why do they, if they want to solve their wait time problem, they could just spend more money. How do you, get more technology? Oh, you just spend more money. They just won't, because they're like, we just can't, because there's no political will, or because the money's being spent on something else. But most countries spend about 8 to 10% of GDP on their healthcare, which again, that's a percentage of GDP, since we have the largest GDP, and we're spending 18%. We spend more than twice in terms of like dollars what any other country spends per person. If they spent that much money, no problems. But again, it's like but it's weird to me, because like that's what would solve it. They just won't do it, and so they live with things not being as good as they could. So the thing that they think is easy, which is figuring out how you're just going to cover everybody, we can't seem to wrap our head around and get done. And the thing that they say is impossible, we're already doing. So if we're willing to spend that much money, let's just spend it better. Make better choices. Like, we've already done the hard part. Let's just, and fine, everybody wants to spend that much money and make this an enormous jobs program, and people will make, I don't care, fine, we're doing it. We can keep doing it. We can keep blowing $4.4 trillion a year on this, but we could certainly spend it better.
How much of that money do you think is kind of wasted in terms of the interests of the very few? And by that, I mean investors and executives.
The problem is that, it's, when we say waste, it's not money that they put in a field and light on fire. It's revenue. It's people's incomes. It's, 18% of GDP means it's 18% of our economy, is healthcare. That's lots of people's jobs. That's their income. That's their, their insurance. That's what they make. So you can't just it's not like we can just say, oh, let's just stop spending it. That would literally cause a depression. If we reduce spending that much, by definition, if you drop GDP a couple of points, that's how you get into a depression. So I don't even argue anymore about let's, spend so much less. Fine, we're spending it, but we could use that money for better things.
What I mean, though, not as just your rank and file employee at a hospital or a doctor's office. I mean the executive pay and the shareholder price of hospital systems, publicly owned hospital systems, much less, insurance companies, because it would seem that that's where some efficiencies or some capital that you could be using.
There's some, but that's actually my point, is it's probably still remember, people all the time are like, oh, drugs cost too much. Drugs are why we spend so much in the United States. It's all the high price of drugs. It's those greedy pharmaceutical companies. What do we spend on pharmaceuticals a year in the United States? A couple $100 billion? Let's say $400 billion. Let's make it really high. I just said we spend $4.4 trillion on healthcare. If we literally said drugs for the next year are free, 100% free, no profit, no nothing for any pharmaceutical companies, we would still be spending $4 trillion on healthcare, more than every other country in the world. It's all of these things we think of as waste are tiny components of the spending, because the spending is healthcare. We spend it on healthcare. It's not like there's $2 trillion of administrative waste, or $2 trillion of greedy executives, or even shareholder benefits. It's if we zero out any of these things that we think of as the cause, we're still spending $4+ trillion on healthcare. It's the whole system that's expensive. Everything's expensive.
You talked about when you go to these other countries and study their healthcare systems, what do you actually do? You talked about the differences with, say, their hospitals, and some are a lot better. They have better amenities, and then later on, I think you mentioned food and something else. I mean, where do hospitals spend money? How could they save money? Did you go into them and see
Yeah,
them? And talk
yeah.
to
I mean, so it's usually a mix of hearing from people that work in the Ministry of Health, or whatever the corresponding group would be in that country. Usually, you talk to some hospital execs, you talk to insurance execs, you talk to you hear from physicians, you tour the hospitals, you see a clinic, you learn about the public health system, you see how some of the safety net programs work. Luckily, I mean, again, it's a privilege. When we do it with the Kelly School, they work with companies to set up itineraries and do this. And when it was the tour of Singapore, Australia, and New Zealand, again, it was working with a company that does healthcare tours, who sets up all of these meetings. And then then you have dinners with people who come and speak to you, and they can be experts on the system, or they could know about they could be an economist or something. So you hear from experts, and you actually see how all the pieces work together. And there's something to it, to actually seeing it all function, because it's just too easy, especially in the United States, to get stuck with American exceptionalism and just think, oh well, we're ours is the best, and anywhere else you would just die if you get sick. And when you see other hospitals, they all look the same. They all look fancy and nice, and then there are some which are not, and clinics look like clinics, and there are ones you see where you're like, oh, that looks just like the place I work, even if it's a good place or a bad place. And you talk to people, and you see how the whole thing holds together, and you realize that we imagine somehow that there's all this special technology and amazingness that happens in the United States that doesn't exist elsewhere, and of course it does. Cities look like cities, and in most of the countries you compare ourselves to, these systems work, and the doctors work. It's just that because of the way they're set up, they're able to keep prices down, and they refuse to some extent to spend as much money, and so the whole thing is just pressured a bit to cost less. And I think that they spend less on things that shouldn't matter, but we make them matter. Like I would say amenities. And in Singapore, it's like literally when you go to a hospital, there's tiers of care. C level, there's like C1, C2 is like bare bones. You might be in a room with 10 people. You get whatever doctor's on that day. You share a bathroom, but that's free. And then there's like A, B1, B2, B2 plus, and at each level, you're not getting fancier drugs or better procedures. You're just getting, maybe you'll share a room with one person, or maybe you have a private room. Maybe it'll be air conditioning. Maybe the doctor you'll pick, and they'll come to see you 3 times a day, and you'll have air conditioning, and you'll get your procedure sooner than you would. But that stuff doesn't matter as much in terms of outcomes. But if you want to pay for it, go ahead. In the United States, we bundled it all together, and so that's like your only option. Like even when we build new hospitals and stuff, it's all single rooms. It's all they're all competing with new menus and fancy food, and and that all that costs a huge amount of money.
I wonder if any of them have the Apple goggles available
They
to
will.
me.
Someone will. Believe me, it'll be like in the fancy room somewhere.
Doesn't this though all come back to, or isn't the problem, at least in this country, the way that our politics work, the way that government works, specifically the way that special interests spend money? So if you have that big pool of money that we spend on healthcare, you've got the pharmaceutical companies, the hospitals, you've got the physicians' interests groups, you've got obviously the health insurance, and they're all going for those dollars, and they all get what they want a lot of the time because they pay for, they pay donations to congressmen.
Yeah, they do. And so it's like, I fully admit, like, I think gearing up for another federal, let's fix it all in one fell swoop ain't going to work. But,
Right.
the things that I have mentioned, more, increasing the number of public hospitals, like trying to, offer, more bare bones care that would be cheaper, and let people choose. could happen in a state. Choosing to create policies which would make people more likely to be well in general can be done in a state. Go ahead. Like you don't need the federal government necessarily to do. You could try. We could be inventive. We could be creative. We could try to solve some of these problems without, quote unquote, revamping the entire system.
But I feel like even if you did it piecemeal or one part of it, you would still have that same issue with special interest spending.
I mean, do you think that like there's no lobbyists in other countries? Like, you think that these are also economy where like they're not all like completely socialist. Like the drug companies make money in those other countries
Right.
still. Hospitals, private hospital systems do exist and make money in those other countries. They're just not the only choice. And most people choose the public system because it's cheaper. And they, and it's cheaper to them, and they go with their pocketbooks. We don't have we rarely have that kind of choice. Like nobody says, I'm going to choose this hospital because it's cheap. Like that even doesn't like really exist in the United States. We built a system where it's just, it's expensive no matter what you do. And it's baked into the cake.
Wanted to ask you a bunch of other questions before I found out about this New York Times piece, but time for just one, because you've been doing a lot of great stuff at Healthcare Triage. By the way, if I were to go deeper on any one of these issues that we talked about, I'd love to know more about who it is in America that is not covered with health insurance. I don't know if you're going to, at this point, who doesn't have access? Because my brother-in-law, who's like makes very, very little money, just lost it in Michigan, and this 133% above the poverty rate does not seem to be necessarily working. So maybe for another time, because
a quick answer is, remember, there's not a Medicaid expansion in all the states. So if you're very poor and your Medicaid system is bad in a state that doesn't have a Medicaid expansion, the Affordable Care Act did not help you.
Right.
And also broadly, there are people still who even still can't feel like they can't afford it, even with the exchanges and the way they are. And then, of course, there's undocumented immigrants who clearly don't get insurance through the Affordable Care Act. And then there are people who just, refuse to spend the money, and they exist as well. And altogether, that probably totals something like 10% of the population, and that's who's left.
You've been doing some great stuff over at Healthcare Triage around climate. And so I just have one question for you, just to clear it up, because a guy went on Fox News this week, one of these climate deniers named Malloy, and said that it's not hazardous to your health to be breathing in that wildfire smoke. I believe you did a specific video just about that issue.
Yeah, I mean, before this even, like we had written that before. Like, yeah, pollution matters. I mean, we know that pollution matters. If you can see it, why would you think it doesn't matter? Now, is one day going to change your life? Probably for most people, no, or like a couple days. But like, this is not going anywhere. And I mean, it happens, on the West Coast now. It feels like every year. And it's like if it starts happening in the East Coast every year too, it's going to be more and more and more and more of a problem. And putting our head in the sand and pretending like this doesn't matter is silly.
I feel like we actually do regulate pollution a lot better than, say, certain countries. And so you could look at the data of certain countries, like I think China and India, and say, yes, because of the pollution, these people that they live with every day are not doing well. Is that a fair assessment?
Yeah, I mean, yes. And you can look at it even in the United States. Like we've absolutely made a difference. A lot of the stuff that we complain about, acid rain and, stuff that when we were like younger was a big deal. Even the hole in the ozone, like we've done stuff that actually improves things and makes
Reagan regulated chlorofluorocarbons.
That's what is like mind-boggling. It's like there was a problem. We actually made something better. It got better, and now we're like pretending like it doesn't matter and that we can just slide. It's silly.
Thank you very much for joining me. It's been far too long. We appreciate you. We love you. You're one of our all-time favorites. We hope to talk to you soon again.
Anytime.